being said, I'm Dr. David Casey, Chair of Psychiatry at U of L, and it's my honor to welcome our guest speaker for today, Dr. Joseph Bienvenu. Dr. Bienvenu studied psychology at Tulane and medicine at LSU in Shreveport. Then came to Johns Hopkins for a psychiatry internship and residency, followed by a psychiatric epidemiology fellowship and a PhD in clinical investigation. And he's still at Johns Hopkins 30 years after arriving and is now full professor. His research background is in epidemiology and genetic epidemiology, focusing his clinical and research efforts on anxiety disorders and common comorbid conditions. In the last 15 years, he's worked with colleagues in critical care medicine on long-term outcomes research, including PTSD. And his topic for today is going to be post-traumatic stress phenomena in critical illness intensive care survivors. So welcome, Dr. Bienvenu.
Thank you, Dr. Casey. Is it okay if I share my screen?
Please do.
It's an honor to be here with you guys. I was asked to flash this on the screen. I don't know if the activity code is important or what, but I understand that was enough. So yes, it's terrific. I'm very honored to be invited to speak today. So I have, as Dr. Casey said, been here for 30 years. This is pictures of Johns Hopkins Hospital. Over here on the left, we have the very first Johns Hopkins Hospital building. And on the right, we've got the newest buildings on the left side of the right picture are our critical care units. And actually some on the right side as well. I should say I wear a bunch of different hats here at Hopkins. That is, I run our inpatient consult service as well as our anxiety disorders clinic. And finally, the residence outpatient continuity clinic. And here we go, objectives. So I want to talk specifically about something that I had no idea about when I first got into this about 15 years ago, that patients who've been critically ill can have quite substantial post-traumatic stress disorder symptoms. And these symptoms are relatively common and can be long-lasting after surviving a critical illness. So this was something that really wasn't on the radar of anybody that I knew at Hopkins who was in this field. And I actually got into CL in part because of this research, or I should say back into CL. We want to talk about modifiable and non-modifiable risk factors for post-ICU PTSD phenomena and talk about potential benefits of interventions to improve patients' long-term mental health outcomes. And I should ask, is my sharing of the screen working for you guys, or should I do it a different way?
If you could share your other screen, it would be better. We're looking at the presenter screen.
Oh, I'm sorry.
If you have two monitors, it should be on one of the monitors.
Right, I do.
So give us the other monitor and you'll have your presentation.
Is that the same one, actually?
That's okay. Just put that on what you did. And now on the share screen feature,
No.
you should be able to alt tab. Can you alt tab?
Oh, yes.
Okay, well, that didn't change it, so
Yeah.
maybe live with this. Oh, there you go.
Okay.
Oh, that did it.
Yes. And thank you so much for that. A disclosure, a few years ago, I and a couple of people wrote a book or edited a book called Psychological and Cognitive Impact of Critical Illness. And I'm embarrassed to say, have made probably less than $100 per year in royalties over the last few years on this book. But it really was a project based on passion rather than wanting to sell books. I also want to say before I forget, I think I got invited here by one of the residents there after I was involved in an APA panel discussion. I was a last minute substitution. And so this was down in New Orleans this year. And it was called something like Benzodiazepines Prescribing and Deprescribing, a panel discussion. And they needed someone else for the pro use of benzodiazepines ever in psychiatry. And so I joined Edward Silverman, and we had a couple of geriatric psychiatrists arguing the con, but it was a lot of fun. I think any of us could have argued either side. So we had Ilse Weikers, I don't know if I'm saying her name right, and Donovan Moust. But I wanted to say that I'm happy to talk about benzodiazepines as well if there's time, and to let you guys know that we're going to reprise this debate in our San Francisco APA meeting in 2023. There was a lot of very active discussion at this meeting, and it was great fun, and I think instructive to all who were there. So moving back to critical illnesses, I'm going to show you some drawings and paintings by this guy, Gary Black, who had severe sepsis. And I want you to know about Mr. Black that he is an educator, but also an artist and musician. This just comes up in some of his drawings. But he wrote this book after, being on the verge of death with severe sepsis. And I think it was a cathartic thing for him, but also he wanted to teach people about sepsis by writing this book. And a bunch of us started using his drawings because they're so vivid. So what happened to him was he developed, I think, an upper respiratory illness, and like many patients, eventually went to the doctor about it. Do I need antibiotics? What's going on, etc. And probably went back and forth a little bit. But he describes in the book driving to his doctor's office the day of admission to the hospital and being very ill, insisting on driving himself. His wife is in the minivan with him, and he's sort of bumping into curbs. He's already getting delirious on the way to the doctor's office, and he is very sick when he arrives. And so his physician sends him directly to the emergency department, and he ends up in the ICU. And he draws lots of pictures in this book about his impression of what's going on when he's in the ICU, like being lowered into a cauldron, and all the nurses look like witches, and that they're there to torture him, and he's chained, etc. So it just speaks to the awful distortion of reality of patients who are critically ill on the verge of death and delirious at the same time, unable to really process what's going on around them, but often able to remember this. So he vividly describes paranoia in this drawing. He's got little demon-looking characters throughout, as well as many angry-looking people wanting to stab him with needles, etc. And he has actually a couple of drawings of him trying to break out of the ICU, ripping out his PICC line and running down the hallway. And he is, I imagine, subdued by staff and or security and brought back into his room, and at some point has a real turning point, and as well as kind of a mystical spiritual experience where he really feels the love of all his family and friends, and it is making a turn for the better. And he's transferred to an acute inpatient rehab unit. And he has these memories of awful things that happened, as well as dreams. And, you know, patients will often remember, for example, being put in an oven, being imprisoned, being assaulted, sexually, you can imagine, with the Foley catheters and rectal tubes and various other kinds of procedures, people having chest tubes placed sometimes. I've heard stories, patients thinking, having kind of sort of incorporating this into their dream-like or nightmare-like state, and sort of building a story about it that is remembered so incredibly vividly. Anyway, he describes that to some extent in his time during recovery. And ultimately, he was terrified by the whole experience, and he was is a very inquisitive person, and also quite courageous in that he went back to the ICU, and he really was an active coper. He found out as much as he could about sepsis as he was writing this book. But as I said, I think it was really therapeutic to him to write this. But he's still, to my knowledge, giving talks, active in advocacy for awareness of sepsis. So sometimes these days, we have many more patients, especially in the United States, who are admitted to intensive care units. And due to great advances in intensive care medicine, critical care medicine, many more patients are surviving critical illnesses than in years past. And so people have wondered, well, okay, great. Patients are surviving. How are they doing after survival of critical illness? So just as in the post-surgical long-term outcomes, people got interested in post-intensive care long-term outcomes. And it turns out that there are burdens associated with having survived what in the past would have killed someone. So a group of us, I think I was the only psychiatrist in the room at the Society of Critical Care Medicine back in 2010, got together to talk about these long-term outcomes. We made up the term post-intensive care syndrome, which is really a funny term in that it's not a single syndrome, but a group of already known syndromes. But using the term post-intensive care syndrome has actually really raised awareness that that at least that there are common problems that critical illness survivors have. And the term doesn't refer to, although you'll see people talk about post-intensive care syndrome to refer to PTSD, it's actually a much broader term than that. It has to do with physical weakness due to bed rest, etc. Cognitive impairment, which is quite common to have executive dysfunction and memory problems in particular, and then psychiatric distress-related phenomena, including depression, anxiety, and PTSD symptoms. And PTSD symptoms are the most vivid, but they're not the most common. Just as with other stressors, depressive symptoms are, including PTSD-like stressors. The depression is actually the most common and non-specific anxiety symptoms. Anyway, the early studies were all really focused on quality of life, long-term quality of life after critical illness. And these phenomena help explain why there's often a decrease in quality of life after a critical illness. So just to tell you a few more stories, this is my colleague, Dale Needham, talking to this man who's got a Nerf football in his hand. He's in the ICU. Looks like he's on a trait collar at the time. But Dale is very much a mover and a shaker, and was ended up writing an editorial for JAMA focused on the need to reduce the amount of sedation that patients get in the ICU. You know, at one point in practice in ICUs, at least in the United States, patients were mainly comatose, and we all know that it's much easier to take care of patients who aren't fighting. And certainly we need to have patients sedated if they have very low oxygenation and they're using all of their oxygen to power their muscles, etc. But Dale was following colleagues who've been experimenting with reducing sedation and getting patients more active to prevent this horrible physical debility after critical illness. So he got interviewed about this article he wrote in JAMA, and it ended up on the front page of the New York Times. And Dale and I and a former fellow of ours, Dmitry Davidov, had written a systematic review, or had been working on systematic reviews about long-term outcomes after critical illness, particularly distress-related psychiatric outcomes. And so he said, you should talk to Joe Bienvenu. I said, okay. And so I had a couple of quotes in there. And anyway, there was a big outpouring of responses to this article online as well as via email, etc. And what was most striking is how many of the patients were not concerned so much about their physical debility, but about their awful experiences while delirious and critically ill. So the mental phenomena. And this really fit with the experience of European ICU doctors and nurses who have been following patients, particularly in Scandinavia, after their critical illnesses, not just, discharging them from the ICU and wishing them well, but following up with them. So I'm going to paraphrase an email that I got from one patient who I later talked to on the telephone, and she shared her medical record with me. She said, last year I was hospitalized for 2 weeks, one in an ICU with life-threatening pneumonia. It was the most terrorizing, frightening experience I could possibly imagine. I was convinced I'd been abducted, raped, and placed in some sort of diabolical experimental testing institution. Even after being moved out of ICU, I remained in constant fear and quite delusional at times. I had a head CT because of what the nurse labeled as strange behavior. After 2 weeks, I returned home scared of things I could not even name. My husband took excellent care of me, but had difficulty understanding what I was trying to say about my experience, and no one at the hospital seemed able to explain what had happened. Last month, I started to have horrible flashbacks about the ICU episode. So this was about 1 year later. And she said this New York Times article helped her understand what happened and what may still be happening to her as a result of her critical illness and week in the ICU. And she found that it was great relief to know that she wasn't alone, that we and others had started studying this. And for her, it was important to know that she wasn't at fault somehow. So I just thought this was a nice email to talk about these common experiences that patients have, and they often feel kind of alone because if there's no one to explain to them at the time what delirium is, what she actually went through, not just an infection, but what was going on in her brain. And, if she and her husband were told at the time they were there in the hospital, they didn't process it. She didn't remember it. Her husband didn't process enough of the mental explanation to be able to let her know, oh, you were delirious from this bad pneumonia you had. So I'll move on. Just want to make the point. I know how, if any of you guys have ever been critically ill, I have not, to my knowledge. But we as psychiatrists can often put ourselves in patients' shoes. So think about what patients who are critically ill experience. So respiratory insufficiency, the feelings of dyspnea, having low oxygen is incredibly anxiety provoking to humans as well as all animals. Having abnormalities and carbon dioxide in the body is also very anxiogenic, whether too low or too high. Patients who are critically ill, one of the reasons that they're often given opiates appropriately is that they have pain and are unable often to communicate it normally if they are intubated. But they have the intubation itself, they have the arterial lines, they have all kinds of things going into their bodies that can be painful. And deep suctioning is also highly noxious, but necessary for patients on a ventilator. With infections, they often have severe systemic inflammation. So release of all kinds of cytokines that affect the blood-brain barrier, cause it to be leaky. They have hyperactivity of the HPA axis, although often the adrenals are kind of sluggish in the context of sepsis. So we end up giving exogenous catecholamines, which cross the blood-brain barrier in the context of sepsis. And we often, or we sometimes will give corticosteroids as well. So patients are delirious for a variety of reasons, not just the medications. Dr. Casey and I were talking about benzodiazepines and antipsychotics given to delirious patients to deal with agitation. Of course, patients are delirious because they are given sedatives, delirious and or comatose. But the illnesses themselves cause delirium. Organ failure causes delirium. Being immobile contributes to delirium. Being in pain. And if you're on a ventilator, you're not going to sleep normally. And as we know, patients with delirium often have perceptual disturbances. So visual hallucinations are relatively common in patients who are critically ill and delirious. And then believing people are trying to kill one or to harm one are also very common in patients who are delirious and critically ill. So all this is happening in the context of not being able to communicate normally and really a complete lack of autonomy. So patients really are kind of helpless while they're critically ill. So I mentioned that Dimitri and Dale and I, along with some other folks from medicine, had started systematically reviewing the literature. So we published this paper in General Hospital Psychiatry in 2008, systematic review of PTSD and critical illness survivors. We found that about 1 in 5 patients had, survivors, I should say, had clinically significant PTSD symptoms. And this was usually measured with questionnaires. So questionnaire measures of PTSD that went beyond an arbitrary threshold. At the time, there were a smaller number of studies that employed clinicians to do diagnostic interviews, and it's a slightly lower number who had met full criteria for PTSD, but certainly it was a lot higher than you would expect based on the general population point prevalence of PTSD. So we were also interested in risk factors, and we found that in patients who'd been critically ill, just as in patients with trauma, other kinds of trauma like combat, sexual assault, etc., other things that are recognized causes of or traumatic events associated with PTSD, anxiety and depressive disorders, having a history of these increased one's risk of having post-intensive care PTSD symptoms. The data were a little bit murky in terms of how agitation, amount of benzodiazepine and opioid sedation could be related to PTSD symptoms. Certainly, if you were agitated in the ICU, if you required physical restraint, if you were on higher doses of benzodiazepines and opiates while you were critically ill, you had a higher prevalence of PTSD. But it's hard to know how much we're talking cause or effect. That is, patients who needed more benzodiazepines were also more agitated, typically in the ICU. So I look at that as really a marker of risk for PTSD. So post-ICU risk factors, so things that have been measured after the ICU. If you get out of the ICU and you remember thinking that people were trying to harm you, if you remember seeing children with no heads or blood spiraling from the ceiling, if you remember these nightmare-like experiences shortly after you get out of the ICU, you're at increased risk for longer-term PTSD, so with months and years later. Similarly, if you have a lot of depression, anxiety, acute stress disorder symptoms after you get out of the ICU and are no longer delirious and able to talk about it, you're at risk for a longer-term PTSD. This is one of my favorite studies, so I always mention this. This nurse in the UK did a lot of very excellent work in this area, Christina Jones. And one study she did was a hypothesis generating study looking at the various things that had been measured in these European centers to see what predicts PTSD symptoms in patients who had survived critical illnesses. So she was very interested in these memories that many patients had told her about, many patients who had survived. And she calls them delusional memories. I am a stickler enough not to like that term in this context. I think of them as memories of in ICU persecutory delusions, nightmares, nightmare-like experiences, hallucinations, etc. She found that these were not, so these were strongly related to PTSD symptoms, but they were strongly predicted as well by a patient's past psychiatric history, which is interesting. So, as we know, we're not all of us exposed to a trauma don't develop PTSD, but this study suggested that patients were also not randomly likely to have nightmarish experiences in the ICU. So it's something about us as patients that brings something. So sedation, amount of sedation, and as I said before, was associated with PTSD symptoms, physical restraint, etc. So thinking about what can we do to prevent long-term distress symptoms in critical illness survivors. So, 1 in 5 patients with clinically significant PTSD symptoms. I think what is usually done is not very much, although that's starting to change. Unfortunately, there's no kind of regular clinical pathway for patients who have been critically ill. They tend to be transferred to medical units, sometimes directly to nursing homes, and follow up by non-intensivists. Maybe they'll get a psychiatric consult if the patient is having a lot of agitation, psychotic symptoms. But most patients probably don't get a consult. So it's interesting to think about, well, how can you prevent long-term distress? So people have thought about education, something called ICU diaries, doing psychological interventions in the ICU, having ICU follow-up clinics, as have been in place in parts of Europe for many years. Unfortunately, many patients can't get to follow-up clinics for logistical reasons. They have a lot of debility, etc., and other appointments they need to get to. So people have thought about telephonic and computer-based coping interventions. Of course, physical activity and exercise are pretty much good for everything, including delirium and cognition and anxiety and depression. Lately, people have also been using virtual reality interventions for patients who've survived critical illness, in part to explain what they have just gone through. But let me talk in more detail about these. So NICU psychological interventions is a group in Italy that in a trauma ICU brought in clinical psychologists. And what they did was very basic cognitive behavioral therapy interventions, as well as a lot of education of the patients and the patients' families. And so it sort of made the ICU less technical and more understandable and less scary in some ways. And so they had a before and after design and found that, among other things, patients who had been in the ICU during the time of the intervention were much less likely to be on psychiatric medications a year later. So a group in the UK did a large study, and they were thinking, well, it's rare that psychologists are in ICUs, and what if we could teach bedside nurses some cognitive behavioral techniques and interventions, and have them apply them to their patients and patients' families. And unfortunately, it was a completely negative study. All of the negative studies I will say here are published in JAMA. Well done negative studies. Another idea was ICU diaries. So ICU diaries differ than how most of us think of diaries as something that I write, for example, about my own life. ICU diaries are written in the second person to the critically ill patient on a daily basis, if not more often, by clinicians, especially bedside nurses, but also doctors and other people on the care teams, describing what's going on a day-to-day basis. Family members are encouraged to write about what's going on from their perspective, how they're feeling about it, et cetera. And it's not for the patient right then, it's for the patient if they survive. And it's also for the family, no matter what happens. And so the first study conducted by Christina Jones with colleagues in Europe found that there was a statistically significantly decreased risk of PTSD, the diagnosis PTSD in patients who got the diaries a couple of months before the final outcome measure. What they also found is, since they measured PTSD symptoms at both follow-up time points, found that perhaps not too surprisingly, it was the patients who had the most symptoms at the first time point who benefited from the intervention. Although others reported, that it was helpful. The information in the ICU diaries was helpful. So a French group had done a similar study with before and after design, not a randomized trial like Christina Jones had, and it had promising results. So they conducted a much larger study, and found that just having an ICU diary was itself not enough to really budge the long-term PTSD or other symptoms. That's another negative study published in JAMA in 2019. Unfortunately, they didn't measure whether or not some patients benefited from the ICU diary intervention, because they didn't have the longitudinal measures of psychiatric distress symptoms. So ICU follow-up clinics, there's some evidence that patients who are able to attend those clinics have reductions in symptoms of PTSD and other distress-related phenomena. And these can certainly be useful to assess need for ongoing physical rehabilitation, cognitive rehabilitation, memory aids, etc. But really before the pandemic, I don't know about there, but here at Johns Hopkins, we were using very little telemedicine. but our colleagues down at Duke had studies going on to do telephonic interventions with patients, critical illness survivors, like patients who survived acute respiratory distress syndrome, had very promising early findings, and then with a later large study, found that the intervention was helpful, but only in those patients who were substantially distressed at baseline. So my take home from this is that if we're going to be doing a preventive intervention in critical illness survivors, we should be focused on those patients who have the greatest risk for long-term distress-related phenomena. And believe it or not, there are not a ton of studies that really estimate or attempt to predict the level of emotional distress. We have lots of stories about risk factors and systematic reviews, et cetera. But here is one exception of a predictive study using lots of different risk factors to see, can we narrow down the risk factors to see which are really the most relevant and to predicting long-term emotional distress, including of PTSD symptoms. So this group in the Netherlands and Scandinavia found that certainly having a past psychiatric history, for example, of the most common mental illnesses like depression and anxiety disorders, those were associated with long-term risk. However, they kind of washed out of the multivariable analysis so all they really needed to take into account was the early post-ICU symptoms of depression to wash those out. Like Christina Jones before, they found that their early memories of in ICU distress, anxiety, etc. Lack of social support, something I didn't talk about before, but that had been studied a couple of times, or I should say perceived social support. You can imagine that lack of social support is as a risk factor for PTSD after any kind of trauma. But there's evidence that is also the case here in critical illness survivors. And then late middle age, I would be very surprised if that finding held up in any other study, just based on the multiple studies that have assessed demographic risk factors for PTSD. So I don't have that many slides. I have some more we can talk about if we want, but I wanted to conclude early so we have plenty of time for discussion. So in conclusion, critical illness and intensive care are incredibly stressful. PTSD phenomena are common in critical illness survivors. They help explain to some extent the reduced quality of life in critical illness survivors. They're associated with prior psychiatric morbidity, having these early symptoms, memories of these nightmarish experiences, and they're also associated with lack of social support. We have not, I would say it's a very early field. We may be able to prevent or certainly remediate symptoms in patients. And my bias is to favor selective rather than universal prevention or intervention efforts. So thank you very much, and I will stop sharing my screen.
We're moving individuals over onto the panel for discussion. If you have questions, you can raise your hand or enter them into the chat or into the Q&A.
That's right.
Hi, Dr. Bienvenu. Remember me, I'm Arthur. I'm the resident you met over at the APA. So I just want to say hi and thank you again for doing this. It's a great pleasure to have you. If you don't mind me asking, I noticed at the end you mentioned that late middle age is considered a risk factor for ICU PTSD or post ICU distress disorder. Why do you think that's not the case? And could it possibly be the case because late middle age is possibly when people's cognitive decline starts happening, so that they're more at risk for developing delirium, and that might then cause them to develop PTSD or relate to their delirium?
That's a great question. Thanks, Arthur. And thanks for reintroducing yourself. Without you, I don't think I would be here today. My main reason for saying that is just based on the multiple prior studies that have not found that a particular age group was associated with, had a strong increased risk for post-intensive care unit psychological or psychiatric distress. So that I just wanted to point out that one study had found that as a risk factor, and in fact, an independent risk factor. But people always say, well, PTSD and depression are more common in women in the general population, and we don't see that in critical illness survivors, believe it or not. Yeah, so I didn't think any particular demographic group there was strong enough evidence. If anything, just looking over the whole literature, some studies have shown increased prevalence in women, but it's not been consistent. And some studies have shown increased prevalence in younger patients. So it's really a mixed bag.
Makes sense. Thank you. I'll see you at APA again this coming year.
Terrific.
Yeah, hi, this is Dr. Huang. I really enjoy your talk. Just some comments and question. So basically, there's a saying I really like. It goes, the ability to heal is the ability to harm. Certainly, a lot of times, even though it's life-saving intervention, and then we're doing extraordinary things to who's almost died, so all those things, is appropriate in that circumstances, later on, could have a long-lasting harm, to those patients. But also, like you're saying, it's multifactorial, and so I'm saying, there's basically, there shouldn't be a one cookie cutter, fix all kind of approach. There's always different factors come into play. And then but in the dementia literature, so in the old days, I think they used to do reorientation therapy. So they come to the patient saying, oh, right now it's 2022, it's not 1950 anymore, your wife died, everything. And then those patients tend to become more aggressive, agitated if you keep doing that. So you have to lower yourself to their level. And then so I'm kind of wondering, how does that apply to the delirious population? And then I think there's this huge debate, I believe, coming out of Harvard. I think they were saying absolute no antipsychotic, to treat this kind of, to be used, but I'm not sure I agree with that, so would you please make some comments about that?
Yes, thank you. Dr. Casey and I were talking a little bit about that particular issue right before we started. So I'm guessing the people at Harvard who are saying we shouldn't be giving antipsychotics to delirious patients are the geriatricians, like Ed Marcantonio and maybe Sharon Inouye. And I think what I would agree with is that antipsychotics are probably not a treatment for almost any form of delirium, that is the delirium itself. Rather, they are measures which can possibly, and this has not really been studied substantially, but possibly can reduce the risk of harm to patients and staff of quite agitated, delirious patients. But I think most of the sort of pharmacological interventions for delirium itself are not that promising, and can cause harm potentially. But that, at least in my mind, I think of antipsychotics when treating delirious patients who were horrified or kind of extremely frightened, that is, who were having hallucinations or frightening delusions, or are trying to get out of bed even though they're very weak, etc., and get very agitated, but particularly if they start fighting with people. But this is not usually what's been studied. What's been studied is, does Haldol treat delirium? Does it reduce the length of delirium? Does it reduce the incidence of delirium? And I think delirium has so many causes in patients who are critically ill that it was probably unwise to expect that Haldol or ziprasidone would be treatments for delirium. I hope that makes sense.
Yeah, that makes sense. Thank you. Yeah, one more question. So basically, instead of doing a double-blind placebo-controlled study of medicine in treatment of delirium, can they do a double-blind placebo-controlled study of caregivers or different therapeutic approach?
Yes. So I know Sharon Inouye, one of those, I think she's still at Harvard, geriatricians, who really was kind of doing delirium research at a time, and a lot of people in internal medicine, at least, were not focused on delirium at all. But she was an early advocate of the non-pharmacologic interventions to help patients with delirium by having companions who could do things with the patients to keep them active, etc. I think it's called the hospital early hospital. It's an acronym. Help, but I can't. Elderly Life Program, maybe something like that. It's focusing specifically on the elderly who are at the highest risk for delirium. All the non-pharmacologic interventions, which do definitely have a measurable effect, and these are often provided by volunteers, and I think they're great. I think in the ICU setting, I don't know if anybody who's done that kind of intervention. There's so many things going on with patients who are critically ill, but people have started to explore. There's a group at Mayo, in fact, who's studying. They're calling them ICU doulas, but what they are people who stay with the patients and explain what's going on to them throughout their ICU stays, and that is early research at this point, but we'll see how it turns out. I think they could have a benefit, just like those clinical psychologists in that Italian trauma ICU seem to have a benefit for patients who survived.
Thank you.
I like that.
I have a question. I put it in the chat. This is Dr. Christine Adams. I'm a child and adult psychiatrist for about 42 years now in private practice, outpatient practice. And thank you for the lovely overview and update. This is not my wheelhouse very much, but I've worked a lot with PTSD in children and adolescents, and also in some in adults. And I'm wondering if there are any personality distinctions that you found in who gets PTSD, anxiety, and depression in these critical care treatment scenarios, maybe by interviewing the family about their premorbid personality type. I ask that because it's been my finding and observation that people that are very highly controlled in their personality style are more likely to get PTSD when things in their life fall out of their control, or their aura of being able to control it. And just wondered if you could comment or share observations or any research you've done or know about in that regard.
I love that question. I don't think I put in my bio that I'm a big personality guy, and that's really, I was interested in basic personality traits and how they relate to longitudinal risk and genetic risk for anxiety and depressive disorders. There hasn't been a ton of research on personality characteristics as they relate to critical illness related post-traumatic stress disorder. But I just anecdotally, what you say about the people who feel like they have to be in control. I mean, this would be a horribly traumatizing thing to a person who feels like they have to be in control because they can't. And their hands are in the lives of their lives are in the hands of others. And I've had the experience of patients saying that even their loved ones seemed against them at the time they were critically ill. One lady told me that she saw the nurse talking to her husband, and they were talking about how if she didn't have this lucky number, they were going to have to kill her. So, but my bias would be, so when I think of control, I think of obsessive compulsive personality traits, and I think the anxious cluster is most strongly associated with anxiety disorders. So the avoidant, dependent, obsessive compulsive. And in terms of general personality traits, neuroticism or proneness to negative emotions. Sometimes I think particularly in the child psychiatry and psychology literature, this is referred to as emotionality or negative emotionality, negative affectivity. So I would guess that, as in PTSD and other phenomena, those, measuring neuroticism is to some extent similar to measuring history of anxiety and depressive disorders, just because it's sort of a risk factor for all kinds of emotional distress related disorders, and can also be affected by them. In the more general PTSD literature, patients who are introverted are at increased risk for PTSD given a trauma. However, they are less likely to be traumatized in certain ways. So extroverted people tend to experience more traumas, to be in more situations where they could be traumatized, but those who are introverted are more likely to develop PTSD given the trauma. My understanding of that is that extroverted people get more social support, and they're more active at baseline, so they're more likely to get out and interact with the world, which is something that patients with PTSD really don't want to do, because the world just seems so much more dangerous than it was. And in this population, we're talking specifically about Hospitals seem like dangerous places to patients, but also illness. So a common cold can seem horribly dangerous to patients who have been critically ill with acute respiratory distress syndrome. So I don't know, that was a lot of blathering. I should say pessimism has been associated. Everybody uses their own version of a personality measure. So pessimism has been associated with PTSD symptoms. As you might guess, in none of the studies do we have premorbid measures of personality traits, unlike some other PTSD studies.
Thank you.
Dr. Bienvenu, I did not hear you use the term illusion, which is sometimes used to describe perceptions in delirious patients. It may not be central to the theme of the talk, but I was curious about your take on perception and how we define or describe perceptual issues in delirious patients.
Thank you very much, Dr. Casey. It's a great question, and certainly illusions are quite common in patients who are delirious. And it also leads me to back to my nitpicky disliking the term delusional memories. For me, a delusional memory is, for example, I wake up this morning and realize that I was abducted by aliens 10 years ago, and that causes me a lot of distress. It's not a memory of being delusional or a memory of having nightmarish experiences while critically ill. These patients remember what they were thinking to some extent, or how they were processing what was happening at the time. And it's interesting in that patients can be much more cognitively recovered. For example, they would pass a delirium screen, but they would still have these memories of things seemed so real that people were trying to kill them. And of course, people don't want to seem psychotic. I mean, most of these patients I'm talking about are patients with no history of psychosis ever in their lives until they were critically ill. So the patients will often cover it up as well. You ask them, I found that if I don't ask, often patients will not bring up how they're feeling. That is, they just look withdrawn and anxious, maybe, like the woman who wrote after the New York Times article. I think people she sent me her chart, and people recognized that she was confused, but they had no idea that she was that she thought that everybody was trying to kill them, kill her. Or that she was psychotic. There's no mention of that in her chart, and there was no psych consult in her, as you might guess. So for her, it was just, why did her husband was just said, this, I don't understand what you're talking about. You had pneumonia, and then you got better, as opposed to you were delirious, and that's why you remember these things. You were on the verge of death at the time, so the memories were really potent, just like our memories of most severely traumatic incidents are quite potent. But I think of it as like our lizard brain remembers these things, and then the cortex tries to make sense of it. But it could still trigger substantial anxiety, even if you know that people weren't trying to torture you or sexually assault you, etc.
Thank you.
I have another question that I just thought of, Dr. Bienvenu. It's Christine Adams again.
Yes.
Is there any, are there any studies done or any observations about how healthcare professionals fare in the ICU in regard to these things? Thinking about the fact that they have more knowledge of what all those tubes are and what are those bottles hanging up, and have knowledge of the names of medications and what they're being given more than the average person.
Thank you so much. That's an excellent question. That a couple of years ago at the Academy of Consultation Liaison Psychiatry, a surgeon who had been critically ill shared his experiences, and I give him a lot of credit. He agreed to do this. I think he had spoken to the chair of psychiatry at the institution. I don't even remember what the institution was, about his experiences, and he shared his experiences of being delirious. I think one of the really nice things about when a healthcare professional is willing to share these kinds of things publicly is that the rest of us can read it and say, oh my goodness, I can imagine what that's like. But he did a brilliant job of saying, of expressing how helpless he felt, how he wasn't able to think straight, and he really was rocked for a while after his recovery. He is doing much better now, and he's got a very strong relationship with the Department of Psychiatry, and says, you know, we need more psychiatry throughout the hospital here. So he's been a great advocate. I think another experience I've had a few years ago at the American Delirium Society annual meeting, we had a former dean of a major institution. It's a research institution, teaching institution. And she is very bright, as you might guess. And she spoke specifically to us before the meeting as well as at the meeting about her experiences. And it was absolutely clear. She was one of those people that she got out of the ICU, transferred down to the floor, and says to her husband, why didn't you do something? They were stripping us all naked and laughing and pointing at us while we were in the ICU. And her husband, she just looked at his eyes and immediately shut up, because she realized what she was saying would sound crazy to him. I hope none of you are offended by my colloquial use of the word crazy. But it really is eye-opening but I would guess that it could be less frightening depending on sort of the level of awareness about what's going on around you. I've certainly had the experience of talking to colleagues who've been delirious, who can say after the fact, I was delirious when I was talking to you the other day. And they understand to some extent what's happening, but I think it can be like patients with dementia at stage who kind of lose awareness at the time, or some awareness. Sorry, that was a really long-winded and confusing answer, but there are accounts by healthcare professionals, usually kind of like a piece of my mind, but you can find them in BMJ and other journals, first-person accounts from doctors who have been critically ill, and what it was like, and the feeling of helplessness, etc. Makes them more compassionate, certainly, to patients in the same situation.
Yes, thank you very much.
Dr. Rabbani has hand up.
Hello, are you hearing me?
Yes.
Okay. I want to thank you very much for this very interesting talk. And I am a retired psychiatrist. I want to share with you a personal experience I have with this issue. I have a son who 6 years ago underwent a very traumatic accident, car accident, and he was in SICU. And for 1 week, he was comatose because of giving him pain medications and also strong benzodiazepines. And I could notice that sometimes he was very much delirious. Every 5 minutes, he would shake his head and he would do actions like he's doing something. So it was very much disturbing for us to see him that way. I was trying to assure him that he is in the hospital, this and that. And the nursing staff, doctors were telling me that he won't understand anything of what's happening with him because he was in comatose then. My question is that during that time, obviously he won't remember those things. Oh, before I go to that, so he when they were trying to take him off these medications, to take off the respirator and those kind of things, then during that time, for maybe a couple of days, he was delirious and he had illusions and deliriums related to those illusional things with the instruments, with the light, everything. He was interpreting them to be something dangerous, to him. And he can remember those experiences, but he is not talking about, and he does not remember anything of during that time, the week that he was comatose. So I am wondering if he was able to hear us, and he was not able to say something. Of course, he was in respirator on, and all those things. Or that no, he won't. He did not understand those things. He was delirious, but he won't be cognizant of that. And then the second thing is that and then when he woke up, he was out of coma. Then immediately these staff would come. They're checking his cognition and this and that, and make him more disturbed because. He was saying that, what is this? Why are they doing this? He was hoping that he would do it well. This is like a test, an exam. I don't think if those kind of things immediately after a comatose state is good. If there is anything or anybody who can change that, maybe they should let him for a few days to get back to himself, then do it. Of course, he may be still not cognitively well. Actually, he was doing well. That was interesting. When they were asking him questions about the date, not perhaps a date, but some other things, he was doing it well, but he was very nervous that he does well. So,
Yes.
And thank you for doing it. And then my other question, maybe you mentioned something that in these kind of cases, when they have pain, they have to put them on opioid medications and they have to put them on benzodiazepines not to be disturbed. So what can they do? What other medication they can give them?
Great. Yeah. Great questions. Thank you so much for sharing that experiences and your thoughts, Dr. Rabbani. So the first of all, the issue of what can patients process? This is something that came up at the Academy of Consult Liaisons on Psychiatry this year. There was a huge interest in ICU-related psychiatry. Maybe a logical consequence of just going through a pandemic and everybody thinking about ventilators and that sort of thing. But a few groups have been very active in ICUs, in, for example, medical ICUs. I'm not sure about surgical ICUs. But one thing that comes up for me is I'm never really sure what a person's going to remember. And you know, if the patient is comatose, I think it's natural for us as physicians, and maybe sometimes even family members to assume that the patient well, may not have conscious memories, like your son did not have conscious memories of his time comatose. But I think we can be surprised sometimes that people there at all may actually be processing some things. So maybe, even if they don't consciously remember it, I think it's, well, my bias would be to try to reassure, even if the patient seems comatose, try to explain what's going on. Because I've also heard from patients who had the experience that no one was talking to them. People were just doing things to them. No one was explaining what was going on. And it may not be that they remember correctly, but it also could be that we, the clinicians, were not saying why we were doing what we were doing, trying to reassure the person that this may hurt a little bit, but it's going to help with this, that, and the other thing. And just trying to be a reassuring presence to those patients who are somewhere along the spectrum of delirium to coma. And I really do think of it as a spectrum. And I know I'm not alone in that. And in terms of so we also have been, ICUs have been better about measuring delirium and coma in critically ill patients. In the bad old days, we just had everybody comatose, and so patients were in ICU much longer, and you know, it was harder to wean them from the ventilator. In terms of medications that may be less deliriogenic, there's an anesthetic called dexmedetomidine, or Precedex. It's very expensive still, I believe, but it's related to drugs like guanfacine and clonidine. So it is much less deliriogenic than benzodiazepines or propofol, and we use it.
Propofol.
Yes. So we use dexmedetomidine to help facilitate extubation in patients who otherwise would get so agitated each time their medications are reduced. It's not a good drug if you need the patient to be deeply sedated, though, because it does not produce deep sedation even at relatively high doses, and it can only be given in a fairly high level monitored environment, because, you know, it can cause hypotension and that sort of thing. So that is one thing that people have been doing. But yes, I guess what we've learned is, if we want to reduce the amount of delirium, generally we try to use as little sedation as possible. Sometimes deep sedation is necessary clinically, though.
Thank you very much.
Dr. Bienvenu, when I'm seeing a person in the ICU, I'm interested not only in what the long-term consequences of the illness might be, or what the long-term consequences of the treatment might be. I mean, obviously those are important considerations, but reducing the person's suffering or the likelihood that they might injure themselves or others in the immediate period of time is also important. And we shouldn't forget that, because that's really mostly what we're about when we're prescribing. Having said that, it seems to me that the treatments that we offer are fairly inconsistent and much influenced by the personal culture of the immediate culture of the ICU or that institution, or the preferences or experience of the prescriber. We don't seem to rely very much on things like treatment guidelines and the like. I thought about this when you were talking about precedents, because that certainly seems to be the case. We don't prescribe it very much as psychiatrists. It's not sort of in our wheelhouse to do that. I see it prescribed, but there's a random quality to it, as to whether the prescriber is comfortable, knows about it, is comfortable with it. But what are your thoughts about a more sort of organized sort of treatment guideline approach that would say when it's more appropriate to use one approach or another medication approach?
Thank you so much. That's a great question. Absolutely. I mean, just even the different ICUs at Johns Hopkins, the neuro ICU has different cognitive measures than any of the other ICUs at Hopkins, and they have been using Precedex the longest, and partly because they can continue to do neurological assessments, serial neurological assessments more easily than if they were using midazolam or propofol. But I think, and I actually made the argument to our Pharmacy and Therapeutics Committee about Precedex. And I said at the beginning, I'm never going to prescribe this. But we wanted to be able to use it for those agitated, delirious patients that were hard to wean from the ventilator. So I did it with my colleague, Dale Needham. But we got it for this specific indication. But people have been using it quite variably over time. And the idea of guidelines for delirium, I think, is very important. At the ACLP meeting just earlier this month down in Atlanta, I have been the vice chair of the Guidelines and Evidence-Based Medicine subcommittee. And this subcommittee hasn't written guidelines in forever, but is just starting to. And there was a lot of interest in guideline development, not only in that group, but also in the new ICU special interest group. So I think that this is likely coming, and it's going to be most effective if we can partner with our colleagues in critical care medicine as we're making this. Because they've gone through this process before, and we should have a seat at the table in terms of what is known to be effective for the treatment of pain, agitation, et cetera, in critically ill patients. Dr. Adams.
Yes, thank you. I have another question. I think that reassurance might be good in some situations, but for the people that are quiet and not super agitated, would it not be helpful to say to them in a psych consult or a psychologist coming by, or even the nurses, is there anything you are afraid of, or is there anything scaring you or that you're worried about right now with all these machines going on and all these tubes hanging over you, to sort of open up the insides of the person by getting them to say, oh my gosh, somebody wants to hear about these nightmares I'm having and these horrible things I'm seeing.
No, I absolutely. Yeah, I was mainly talking about those patients who couldn't talk, who couldn't answer the question because of a tube down the throat or a tracheostomy without a speaking valve and that sort of thing. Of course, we can get the patients to write if they have the strength, and there are other kind of communication techniques. But absolutely, is there anything you're worried about? I found it necessary to go even further and say, I've seen a lot of patients who survived critical illnesses like yours, who feel like people were trying to kill them. while they were in the ICU. I'm not saying that you have that, but I just want you to know that's common, and to sort of destigmatize the idea to the patient, and just bring it up out in the open, because I've seen people just sort of remain quiet and deny things. So I sometimes find it helpful just to say that out loud, as a spark to conversation.
Yeah, even if they can only shake their head in acknowledgement, you've made a connection with them that you want to know what's going on in their inner thinking and observations of themselves. And I always found when I worked on consultation liaison that was really helpful in making that kind of connection.
Yes.
Thank you.
Thank you. And we're probably out of time.
I think we are out of time, and we surely appreciate you spending your time with us. We've learned a lot, and once again, thank you very, very much.
Thanks for having me, you guys. It's a great honor. Thank you.
Thank you.
Thank you.
Thank you, sir.